Presence Principles of Internal Medicine, 20th edition. This is part 4 on Ko and Hannah. Chapter 69, Principles of Cancer Treatment. Cancer presentation, we are on cancer staging. Okay. An essential component of correct patient management in many cancer types is defining the extent of disease, because this information critically informs whether localized treatments, combined modality approaches, or systemic treatments should initially be considered. Radiographic and other imaging tests can be helpful in defining the clinical stage. However, pathologic staging requires defining the extent of involvement by documenting the histologic presence of tumor in tissue biopsies obtained through a surgical procedure. Axillary lymph node sampling in breast cancer and lymph node sampling at laparotomy for testicular, colon, and other intra-abdominal cancers may provide crucial information for treatment planning and may determine the extent and nature of primary cancer treatment. For tumors associated with a potential primary site, staging systems have evolved to define a T component related to the size of the tumor or its invasion into local structures. T component, size of the tumor and its invasion into local structures. Okay, T, tumor size, okay, and invasion. And next, an N component related to the number and nature of lymph node groups adjacent to the tumor with evidence of tumor spread. N component related to the number and number and nature of lymph node groups. N number, nature, lymph node, number, nature, node groups adjacent to the tumor with the evidence of tumor spread. And an M component. M component, what is it? Based on the presence of local or distant metastatic sites. M component. Presence of local or distant metastatic sites. So T and M, T is tumor size and invasion. N, nature, number and nature of nodes. And M is local, presence of local or distant metastatic sites. So T for tumor size and invasion. N for number of node groups, nature of node. Then M for metastasis, T and M. The various T and M components are then aggregated to stages, usually stage 1 to 3 or 4, depending on the anatomic site. The numerical stages reflect similar long-term survival outcomes of the aggregated T and M groupings in numeric. In general, stage 1 tumors are T1, NO or N1, and MO. T1 reflecting small size, NO or N1 reflecting no or normal or minimal node spread, and MO, no metastasis. Okay, T1, this is stage 1. T1, NO or N1, and MO. Stage 1, T1, NO, N1, MO. T1, NO, MO. T1, N1, MO. T1 is reflecting small size, NO or N1 reflecting no or minimal node spread, and MO, no metastasis. Okay. may ara, gamay nga tumor, may ara ang gamay nga spread pero wala mets. Such early stage tumors are amenable to curative approaches with local treatments. So local treatments na. On the other hand, stage 4 tumors usually have metastasized to different sites or locally invaded viscera in a non-resectable way and are dealt with using techniques that have palliative intent, except for those diseases with exceptional sensitivity to systemic treatments, such as chemotherapy or immunotherapy. So, mga late stage, stage 4 na metastatic na distant sites. Kag invaded, locally invaded viscera, hindi na ma-resect. No? So, palliative treatment, na tapos may raman sila, or pwede man nga, kung nag-react, pwede pa, sensitivity to chemo and immunotherapy. Also, the TNM staging is not useful in diseases such as leukemia, where bone marrow infiltration is never really localized, or CNS tumors, where tumor histology and the extent of anatomically feasible resection are more important in driving prognosis. Okay. TNM staging hindi na pwede sa leukemia kag mga neurologic CNS tumors. Kaya tungkol sa leukemia, bone marrow infiltration di man na localized. Kag ang sa CNS and tumor histology, hindi ka man ka-resect na para makakuha ka prognosis. Okay. Next to discuss after this is